Our next presenter this morning is Dr. Eric N. Prostowski. He's an electrophysiologist at St. Vincent's in Indianapolis. He has co-authored 2 textbooks, has 700 plus publications, has been on numerous guidelines committees and think tanks, is on the editorial board of 16 journals, and is the editor-in-chief of the highly prestigious Journal of Cardiac Electrophysiology. He is the most sought-out AFib expert at medical conferences around the globe. And it's an immense honor for us to have Dr. Prostowski with us this morning from Indianapolis to speak with us today. Dr. Prostowski will talk about treating AFib with medications and avoiding strokes. Dr. Prostowski.
Thank you so much, Melanie. It's a delight to be here. I've come here for a rather circuitous course. I was just in Venice at a very large arrhythmia meeting there, I think 2 days ago. Came home, my wife said, well, at least you're going to stay around for a while. I said, I'll be here a day. So anyway, has abandoned me now. Anybody who has grandkids will understand this. My son and daughter-in-law is their 10th anniversary, so they're off on a trip today, and my wife reminded me that she won't be there for a week when I get home because she's up watching the grandkids in Chicago. So this should be an interesting week. I'm delighted to be here, though. This is, let me just say a little bit about Melanie and her organization. I guess it's close to 10 years ago, Melanie? 7 years ago, we bumped into each other at something. I've had an intense interest in AFib and trying to reduce burdens of AFib since almost the mid-90s when we wrote our first guideline suggestions on how to treat patients with it. And Melanie was doing this, her website. We got together. I'm sort of connected in the Heart Rhythm Society, and our alliance started there, and I think her site is wonderful. I've enjoyed reading things on it, and I think it's one of the best things that we have out there for patient education. I think the field owes Melanie and True Hills and her organization a lot for that. So thank you for all the work you're doing. Let me go into what I'm going to try to do today. I'd like to give you a bit of a run-through on these are my conflicts of interest. These are important to put up there. It's interesting in Europe. They go through things. They often don't put these slides up, and I'm thinking, don't you guys have conflicts? They view things very differently there. So first of all, some of the things will be slightly repeated from the previous speaker. There are 4 categories, and patients get a little confused with this because they aren't really as segregated as you might think. And what they're based on is just how long you're in AFib. So for example, if your episode stops on its own, we call that paroxysmal. It's a word that can be used for anything. You have paroxysms of something. That's all it means. It stops on its own. But how long stopping on its own? And we're doing some research now looking at this. You get the feeling that, oh, my AFib lasted 2 hours. Okay, I have patients with paroxysmal AFib where it lasts 3 days. Still stops on its own. Well, what if it lasts 5 days? Same disease, right? Same category, but I don't think the risks are the same. And I'll explain that to you in a little bit. Persistent AFib means it's simply you're in it until someone stops it. So honestly, somebody doesn't like how they feel. They come in after a day of AFib and they get cardioverted. You know, they get shocked back into normal rhythm. Well, if you waited a day, it would have stopped on its own. So if you waited a day, you get called paroxysmal AFib. If you get shocked in the first 5 hours, even if it was going to stop on its own, technically you become persistent AFib. So people say, oh, you have persistent AFib. I'm not sure there's much we can do for that. And it becomes a problem on how you look at these things. So these terms aren't as sort of sliced up as nicely as you might think. Long-standing is a term that came in actually from an article that we published in our journal. Some French authors were looking at a new way to ablate certain kinds of AFib. And they used some funny term that they came up with. And I said, you know, no one's going to understand this. So we sat down together and I said, isn't this really just the same thing as long-standing persistent if it lasts for a year or more? And they said, yeah, we like that. So the term came into the literature. Their manuscript said if you persistent lasts for a year, Okay, now it's long-standing. And then permanent really is in the eyes of the beholder. It really means you can't get back out of AFib. But then you go to somebody who does ablations or surgery, and they say, oh, we can get you back to normal. So you went from permanent AFib, really, permanent, to cured. So that's why these terms are a bit confusing for patients as well as doctors, as well as trials. And it's very hard to figure it out. And what if you have one cardioversion out of 5 years and every other episode stops on its own? Are you persistent? Are you mostly paroxysmal? So when I say this, the reason I dwell on this a little bit is you need to know when some doctor gives you you're persistent. You know, this isn't quite as crystal clear as the doctor may say. And maybe the doctor's confused. Believe me, there's a lot of confusion out there over these terms. So we don't use the term chronic AFib anymore because AFib is basically a chronic disease. And everyone, so in a sense, we dropped that when we wrote the guidelines. So that's at least a run-through of these terms. This is what I use in the office. I developed this with my artists because I find it very useful for teaching patients on their first visit. There are 3 cardinal things that you must get out there right from the beginning about your AFib as far as treatment goes. And one of them has to deal with stroke prevention. We're going to talk about that. The next is the issue of rhythm control and rate control. And they're all important, and they're not segregated like I only do one of those. So this is a slide I made up probably 15 or 20 years ago. I still believe it to my core. The prime directive in the management of AFib is to preserve the brain. Preventing strokes is the key to managing this disease. I've yet to meet a patient in my office who said, you know, doc, I don't care if I get a stroke, just get me back in sinus rhythm. Not at all. Melanie was involved with me on a national project with the famous basketball player Jerry West. I'm sure you've all heard of Mr. NBA. And it was great fun for me because he and I appeared on a bunch of things together, and we were trying to raise public awareness about AFib. And he has it, and he tells his story in a very poignant way. He couldn't even watch, he was the general manager of the Lakers. He couldn't even watch the last game. He went on the highway, as he tells the story, and he just drove around, and he came back because he would get into AFib if he got rattled too much. And I asked him once, I said, well, what bothers you the most, Jerry? And he said, stroke. Stroke is a fear to him. As a very trained athlete, his whole life was spent in, doing things athletically. He said, I'm not going to be in a wheelchair, Eric, or doc, as he likes to call it. It's funny, it's like, he was my idol, so for me just to sit down and have dinner with Jerry West was a thrill, plus being involved in this national program with him. And, I said, well, I'm Eric, and he said, okay, doc. I said, you can call me Eric. He said, nah, he's like one of these old-time guys when you're a doctor, I said, well, I wish the rest of my patients felt that way. But most of them was like, where's that Prostowski guy, So anyway, preserve the brain's key. So you've seen this before, and I will tell you, this is going to create some problems. I was just in Europe talking about this, and this CHADS-VASc2 is a way, the reason it came about is we've always known, even in the original guidelines, that it wasn't only about 5 things. These are acronyms, as you've heard already, and these are stroke risk scores, and if you have, in the CHADS-2 scoring system, if you had a score of 1, we felt that you should have, for that woman out there, the pricey stuff. Actually, warfarin is very cheap, but I understand what you mean. So we feel there you need probably full blood thinners. But so they refined this and called it a CHADS-VASc 2 scoring system. And here's the problem with this. The problem is that it's taken from a different database, and I'll show you why that becomes important. Let's look at your actual risks side by side. So if you have a CHADS score system, let's just take a person who has hypertension, is a man who's 55 years old. You have one risk. You just have hypertension. But I will tell you from my own experience, hypertension is a major risk for stroke. None of these scoring systems have teased out individual components. And the people who wrote this system were at the meeting in Venice, and I challenged him to go back to the database and look each item and see how that added to risk. Because you can do that, but it hasn't been done yet. My own personal experience with patients, hypertension is a major risk for stroke. I think it's more of a risk personally, but I can't prove this yet, than just simply the fact that you're a woman. Okay, so if you're a 28-year-old woman, I mean, really, you have the same risk? Do you really think if you had AFib as a 59-year-old man with hypertension? I personally don't think so. I haven't proved it yet, but I think that's something we have to look at because here, if you have hypertension, you would be considered a 2.8% risk of stroke. Here, if you have just hypertension, you're 1.3%. Well, that's a big difference because, if your stroke risk is only slightly more than the population, do you really want to take a drug that can cause a 1% risk of bleeding? And that's where this issue becomes important. I think it's going to raise a lot of concern among clinicians when they start to have to use this. And I think this will become the standard. So I do have some problems with it. On the other hand, I will tell you, I am a really crazy guy about trying to reduce stroke. It's the first thing I talk about, and I spend an enormous amount of time on it. I want to make sure patients really get this, because I don't care how well I do with the rest of my therapy. If I get that call that Mrs. Smith is in the emergency room and she can't move the right side of her body, I'm devastated along with her. I've had that happen to my father. I understand it from a family member. I've been involved in this for over almost 2 decades now, trying to wrestle with this problem. So I will personally still, even if you're a 1, I will probably be giving you anticoagulants, the pricey type of anticoagulants. Yeah, you could take Coumadin. So anyway, let's go through some of the trials. And I don't expect you're not scientists, or some of you may be, so I shouldn't have said that. But don't worry about that. I just want to show you a concept from these slides. 3 drugs are out there now, what they call the new or the novel oral anticoagulants. I consider them the new oral anticoagulants. The people who developed them consider them the novel oral anticoagulants. And you'll hear these terms NOAC, N-O-A-C, that's what it stands for. But they're the new drugs that are out there, and they're all very useful, and I want to show you that in the trials. I don't know that you can really parse them that carefully. In fact, one of the guys who was involved in each of these trials presented at these recent meetings, and he was pushed by me as the chair of the meeting to tell us which one you want to use, and he refused. He said, it's your choice. So, there's not one of these that are so far above the others. But let me walk through the trials with you. So basically, what you do in these they're called Kaplan-Meier curves. They're named after the 2 people, Kaplan and Meyer, who developed these decades ago for any kind of trials. And what you do in any of these trials is you have 2 therapies, and you enroll thousands of people in these trials. 15 to 20,000 in some of these trials. And you compare the results. And the major result for most of these trials are things like either mortality or stroke or heart failure, things like that. And then what you do is you see how they do over time, and that's how you develop a curve. So in this case, it's the cumulative ratio in here of outcome of stroke or systemic embolism. This is with the drug that's called dabigatran. Its trade name is Pradaxa. In the United States, we only allow 150 milligram dose, so don't even worry about this line. So basically, here are the events that you can see with warfarin, which is Coumadin. Here are the events with 150 milligrams of dabigatran, or its trade name is Pradaxa. So the drug did much better. In other words, over time, there were many more strokes or emboli in the Coumadin group than the dabigatran group, and that's why this became a very popular drug. It's more effective than warfarin. It also reduces bleeds in the brain much more effectively. This whole group does. Unfortunately, there's about a 1 to 1.5% increase in gastrointestinal bleeding. It's been looked into further. It's more related to age. If you're 75 or greater, you have to be very cautious. So these are the nuances that I, as a clinician, will use when I discuss these in the office. They're all very good drugs, but you look at the patient in front of you, you make a decision what's best for that patient. This was the second one to come out. This is the drug rivaroxaban, or Xarelto is its name. And again, you can see here's the warfarin line for a number of events, less events in the rivaroxaban. The nice part about rivaroxaban is it once a day. It's the only one that's once a day. It works by a slightly different mechanism, but none of these drugs require all that INR testing and stuff. But they're all more expensive. They've only been out a couple years, so we don't know 10-year follow-up, and that's something that we always worry about with any drug. It does have a slight increase in in gastrointestinal bleeding. I don't know if it's the same as dabigatran, but it has a slight increase. Also reduces bleeds in the brain. The advantage here is it's once a day, so that's a nice thing. The latest of the released drugs is apixaban or Eliquis, and this was in another trial, and you can see, again, the same sort of thing. You can see here's the warfarin line, here's the apixaban. Now, here was a major difference, and this is a very important major difference for me as a clinician. It also showed a reduction in major bleeding, and it's the only one that really had that such a major reduction. Not sure why. but it was a very nice outcome. So it's also twice a day. So Pradaxa and Eliquis, or either, the trade names, they're twice-a-day drugs. Xarelto is the once-a-day. This Apixaban, though, or Eliquis, has an advantage of reducing major bleeds. So they have advantages and disadvantages, and you need to individualize with your patients. And I will tell you something I found out, at least in the Indianapolis area, I don't know if this is across the country, depending on your insurance plan. And I mean, I'm looking at people out here in the audience. Many of you may be on Medicare plans. It doesn't matter. I've had patients who tell me, I give them all three names before we start. I'll start them in the office with a sample if we need to, but I give them the names and tell them to go back and check. And sometimes they'll say, my plan pays for Eliquis, it won't pay for the others, right? Or it'll take care of Pradaxa, but not this one. I have no idea why that is. I have no idea whether the Affordable Care Act, so-called Obamacare, is going to change that. I have no idea, but I can tell you there are differences. So what I do before putting a patient at economic risk, because these drugs are expensive, I say, here are the drugs. You go back and check. Give me a call. I can start you on any one of them, and let me know which, after we have that discussion. In that way, you don't get yourself in an economic bind. The funny thing is, this is an expensive process for those people who get INR testing. You just don't see it. I asked the patients once, I said, well, I don't understand. I checked into costs. At our hospital, it's $231 if you do it, an INR test. That's a lot of bucks. And I'm thinking you do 12 of those a year, one a month, you're bought into $2,700. So I asked one of my patients one day in the office, I said, well, why are you resisting starting a new drug? I don't get it. You're spending all this money. Not me, doc. I said, what do you mean, not you, doc? He said, I don't pay anything. That's picked up. I said, aha. I said, so I get it now. So it costs you pennies for the warfarin, and you don't pay for the testing. So that's a great deal. For you, but for the medical system, and we don't look at it that way in the United States. Europe and the rest of the world does. They look at the macroeconomics of a system. For the medical system, I doubt if there's that much difference. I mean, if you got in and the government got serious of lowering prices with pharmaceuticals, and you added it all together, I'm not sure these new drugs wouldn't be the same price or cheaper. The difference is, and I understand this, you don't have to pay for the INR testing. So for you out of your pocket, it's much cheaper using warfarin. I don't think there's no one size fits all. This is a very long discussion in the office. This is what takes most of my time in an initial office visit. We walk through this carefully and we decide what's best for each patient. Okay, there's also this thing which I'm not going to belabor because frankly I think it's, I won't use the word silly because this thing will be seen around the world, and I have all my friends in Europe who put this together say, how can we call my Hasbled scoring system silly? So I'm not saying it's silly. I'm just saying it's almost not worth doing because all the risk factors mainly that cause you to be at risk for a stroke also increase your bleeding risk. Hypertension, stroke history. I mean, not all of them, but labile, elderly age. I mean, so the point is, most people who really need a blood thinner also unfortunately fall into risk, usually of people who are more at risk for bleeding. And the fact is, I can replace your gastrointestinal cells a lot easier than I can replace your brain cells. Okay, you bleed in the brain, the game might be over. I'll take the bleeding risk versus the stroke risk as a trade-off any day of the week. Okay, so now we go into rhythm control. And to talk about that, I want to show you a slide that you're not going to bother looking at, and please don't. This is in here mainly to remind you, in case your doctor forgets, all these rules we mentioned about scoring systems for keeping you out of stroke risk and blood thinners, they fall apart when you talk about cardioversion. Everybody who's been in AFib for at least 48 hours is at risk for stroke after cardioversion, even if you're a score of 0. So those rules only apply to long-term blood thinning. Around the cardioversion time, different rules are there. And it's because when the heart has been in AFib for a while, like more than at least 2 to 3 days, the top chamber becomes a bit dysfunctional. It doesn't contract as well. And when you cardiovert that patient, there's actually, believe it or not, even less contractility on the top chamber. And it's a great time for there to be low flow in the top chambers and clots to develop. And that's taken years of research to figure out. So the reason I bring it up is not to let you know about going through this algorithm. Just remember that even though you may have been a person who never was taking a blood thinner, your doctor may say to you, oh, I'm sorry, you've been in AFib for 48 hours. We now have to talk about a different strategy, and that's appropriate. And that's a strategy that has to do with cardioversion. So, when we talk about this rate versus rhythm, there's a famous trial called the AFFIRM trial. Again, Kaplan-Meier curve, I'm not going to go through the details, just want to use it as a setup because it's looking at mortality and people who were trying to keep them into rhythm, in other words, stay in normal rhythm all the time, versus people they said, don't worry about that, let's just leave you in AFib and control your rate, and we'll look at you after a period of time, see how well you did. Found that this is a strategy now. There was no difference in the strategy, okay? People did the same. But I want to remind you that the follow-up in this study was 2.5 to 3 years, okay? So what do we really know about these strategies? And this is something that's becoming, for me, very important. We really know that I'll give you a period of time in here. Most people enrolled were in their late 60s, and there is, that's okay there, but for people who were in their, who are younger than that, there's really no data on the safety of long-term AFib. And people who are older still, there's a lot of question marks. So why do I bring it up? Because there are some new data coming out suggesting people who are at risk of stroke, I mean people who you keep in AFib long periods of time, over time, now you're talking 4, 5, 6 years later, they're starting to show increased mortality in some studies. And that's very worrisome to me. See, that was never looked at. Also, a very complicated slide, but it's in your book. I'm just bringing it up. There's also data out there now saying, and this really worries me, that there's increased risk when you stay in AFib for long periods of time. There's increased risk in Alzheimer's, in senile dementia, and several other things. We recently wrote an editorial on this in one of the journals. There are these things they call silent cerebral infarcts. In other words, if you put yourself through an MRI machine, even though you've never had a stroke, but they're finding out in people with AFib, they've been in it for a long time, they have these little areas there that are silent infarcts. And people are worried that as they accumulate over time, they may be causing decreasing mental alertness. Again, new research, not nailed down, but for me, enough of a worry that I like to keep people in sinus rhythm. Again, I won't go through all the drugs, and there's a very big algorithm you have in your book. Suffice it to say that there are a lot of choices with drugs, and it's individualized to you. What kind of disease you have, what kind of safety risks, it's individualized to you. And the choices are here. You should at least know about them so that you can discuss them with your doctor. Last of all is just controlling your rate. So let's say you are a person that I make a decision, you can stay in AFib. I think it's perfectly reasonable. There's no, there are going to be, you've been in it 10 years, it's going to be crazy to try to get you out of it. It's critically important to keep your rate under control. I'm a sort of a nut on this too. I do it by all outpatient monitoring. I hardly ever bring anyone into the hospital with AFib. The vast majority of AFib care can be done totally as an outpatient. And I give them these monitors, the mobile outpatient telemetry systems, and I give them a drug, and then I look at a heart rate plot. You can see that much of the day this person's heart rate's above 100. To me, that's not good rate control. Then we give them a drug and we ask them to send in another one, and now they're controlled. And we do this as an outpatient until the heart rate's controlled. And when it's under good control, I tell them to send the monitor back, and we stop there. Now, if they're still having symptoms, even with excellent control, it's time to move on to sinus rhythm. So I'll stop at this point, and I'm happy to answer any questions. Thank you for your time.
Can I join you on the stage? So I want to kick off the questions, if I might. And what I'd like to ask you, and let me come over here so you can get to the microphone, is we know that the guidelines say, and you and I have had this conversation many times, we know that the guidelines say that if a patient is asymptomatic, in other words, they're not experiencing any symptoms, then you start with rate control, and you really only consider the rhythm control if they have symptoms. But we know that in many cases, patients have symptoms that they haven't expressed to their doctors. So would you address this whole thing about the symptoms and
Yes.
rhythm control?
Thank you for bringing it up. That's a very critical point. Doctors, especially nowadays, we're all being squeezed. If you haven't seen it in your doctor's office, you're going to see it. There's just so many people out there, not enough doctors, and you're trying to move through quickly. And it's easy to say, how you doing? You have any symptoms? I feel pretty good, doc. Really? Okay, we're going to leave you in AFib. You take a little time, you put your pen down, and you say, I want to talk to you a little bit more. And it's really important if the spouse is there. And it's usually the guy. I teach this all the time. You've heard me say this before, but I've been training people in my field for over 3 decades. And I tell them, and I tell audiences, if you get a new patient and it's a man, and they don't come with their wife, send them home, because you get no useful information. I've yet to see a guy in my office say, yeah, I'm really feeling bad, doc. In fact, the typical scenario is they say, I'm doing okay, and you see the wife. You just have to kind of glance over, and the wife is, like, you can see they're starting to fidget. And I say, and I know what's going to happen, so I tell the guy, let's go through this a little more detail. I mean, are you a little fatigued? Are there things you can't do anymore? Do you feel generally the same? I feel good, doc. And the wife explodes. You've been telling me for 6 months you don't feel good, you don't do this. And then finally the poor guy breaks down and he tells you all the things. So there's subtle things. You just don't have the same energy level. There are things you can't do that you used to be able to do. You know, you sort of don't have the pep that you used to have. And then what you do is you cardiovert them, and you say how you feel now. And not all of them, but most of them say, I don't understand. You know, I didn't think I had any problems, but I feel good. And if you're having a lot of palpitations or shortness of breath or dizziness, that's easy. It's all these subtle things of AFib that become insidious. And you learn to live with them, and you forget how it was 6 months ago or a year ago. So I always, if I have any shot of giving someone at least one chance at sinus, I'll do it. Because it's not infrequent that they'll say, wow, I feel so much better. I mean, I'm getting a better sleep. I can get and do my things. So I'm a pretty big guy on sinus rhythm. But there are some times when the journey's too hard. If you've been in AFib for 10 years, your left atrium is a huge size. And there, Melanie, you sort of have to take a deep breath and say, you know, I wish I'd seen you 9.5 years ago. But for most people, I try to give them that one shot. And like you and I have discussed, many times people say, wow, I forgot I felt this good at one time. So there are a lot of subtle symptoms, and it's up to you. If you don't want to tell the doc, it's up to me to figure them out. Or for sure, it's up to your wife to beat you up a little bit in the office so they come out. So.
Awesome. Any questions? We have one here, Melissa.
Yes, my husband has been diagnosed with PSVT, and I was just wondering, is that a form of AFib or something totally different? It sounds like the symptoms are very similar.
Yeah, that's a really good point. Actually, I'll repeat the question in here. There's a condition called PSVT. That actually stands for paroxysmal supraventricular tachycardia. The truth of the matter is, any atrial rhythm that comes and goes on its own is technically under that category, right? Paroxysmal comes and goes. Supraventricular means it's from the top chambers. Tachycardia, fast heart rate. That's where it comes from. Many years ago, somebody made that in a paper, like this was a specific thing for a certain group of rhythms. So usually when an electrophysiologist talks about that, we mean a different group other than AFib. But technically, AFib would fit under there. So I think what you're talking about are these kind of rhythms. There's a syndrome called WPW. There's a thing called AV node reentry. That usually refers to those, and symptoms can be the same, but they're usually easily treated with ablation, usually one day in the lab and they're gone. So I'd have to know, and often I'll get sent patients with that diagnosis, and you have to pick it apart. So AFib could be called that by some people. It shouldn't be because it has a different connotation, but symptoms could be the same, yes.
Hi. Have you done any studies in regards to aspirin?
Aspirin?
Yeah.
Personally done them? No. The studies on aspirin are, let me just tell you, aspirin is grossly overrated. I will start by saying that. And aspirin does have side effects. I mean, that's one of the reasons why we don't routinely, some of us give aspirin to everybody over 65 like we did 20 years ago, because risk-benefit ratio is really not necessarily there anymore after you've looked at all those studies. There's a lot of bleeding, eye problems. Aspirin is not a benign drug. Having said that, if you look at the whole world of studies on looking at aspirin, Coumadin, and everything else, aspirin was a very, very, very weak drug for preventing strokes. when we wrote the guidelines, I raged against my committee, but I lost on putting some of the things they did. There's really only one study that really substantially supported aspirin. I would tell you that I think aspirin is not to be used in anybody you're serious about reducing stroke risk. If you want to give it to someone who's sort of on the margin, that's fine. But if someone's really at stroke risk, aspirin's not going to cut it.
Okay. And this gentleman here?
Yes, I have had 5 cardioversions. None worked. Had an ablation, stayed out for about 2 years, and now I am back in. So can I just kind of look to do that same procedure over again? How many times can you have a cardioversion, or how many times can you have an ablation?
Those are 2 different questions. Cardioversion, you can have as many as you want if you are a masochist, but I would highly recommend against undergoing.
With the propofol, it did bother me.
No, I mean, there are people who do that. They say, come back every 3 months and be cardioverted. I personally think that's not the best thing to do. I don't think it's hurting your heart, by the way. I just think it's crazy just from a doctor viewpoint. But I would go back and talk to your doctor about another ablation. It's not uncommon that, you'll hear talks later today about ablation. I'll just make a general comment for a guy who's been in this field a long time, done my first ablation in AFib in the 90s. There's a lot of confusion about ablation. And there are camps. There are some people who feel that, oh my God, you have to have this method. Other camps say, oh no, that method doesn't work, you have to have this. And they're usually people who are doing research in the area or who are personally having good results. Let me tell you from a 30,000-foot view of somebody who runs a journal, who's been in this whole area for decades, it isn't that simple. And we have multiple things we use in our own group, and we try to target the kind of ablation to the kind of patient we're dealing with. There is no one-size-fits-all, no matter what anyone tells you. That's really just not true. I think that you should go back to whoever your doctor is and rethink another ablation or a drug. We have these hybrid successes. Sometimes you'll have a terrible time with a drug, then you get an ablation, and unfortunately you get a recurrence, but then a drug sort of cleans up the mess. I always tell patients that imagine that you had to lift you had to lift 200 pounds and you couldn't do it. But if I told you, could you lift 50 pounds, you go, sure. Well, you sort of change the anatomy of the top chamber with the initial ablation, and sometimes the drugs can come in now and basically take care of business for you where they couldn't before. So a savvy clinician has to use all those things. You don't necessarily have to have another ablation. Maybe what you have to do is retry a drug, and if you can tolerate the drug, maybe you don't have to go a second ablation. These are not simple decisions. These are you have to really sit down. But I wouldn't have a Q3 months a cardioversion. First of all, it's just not convenient, if nothing else. I mean, you have to go in and do all that stuff. That, to me, is a sort of not your best approach. Yeah, you could do it, but it's not your best approach. I would go sit down and either have another ablation or maybe now reintroduce a drug that didn't work before, and you may find that you have a really good lifestyle.
Great, thank you. We'll have time for more questions a little bit later. We need to move on,
over
but
here.
I want you to stay.
Oh,
Okay.
yes.
Stay. Stay right here.
I can't, well, my wife's in Chicago, so it doesn't matter.
I just don't want you to leave the stage too quickly.
Oh.
We have a special surprise this morning. We have an award that we would like to bestow
Oh my gosh.
to Dr. Prstowski. It is the 2013 Advocate for Patients Award.
Wow, that's very kind.
Dr. Prstowski has been instrumental in bringing patients to the table with their doctors, with think tanks, in really engaging the patient community with the professional community and helping us to get involved in places where decisions are being made about our care. And in addition to that, he has started this quest on Preserve the Brain to help raise awareness of some of the issues that are not widely known, particularly among the general practitioner, family practice community, so that we can educate patients as well as doctors about what some of the issues are and how stroke is a significant risk, and staying in AFib long term puts people at more risk. So Dr. Prstowski, on behalf of stopafib.org, and the atrial fibrillation patient community, I'd like to give you this award, the Advocate for Patients Award.
Wow.
Thank you. Thank you. So, Jessica, why don't we do a photo here? Okay, great. Thank you.
May
Thank you, Dr.
I know I'm going to leave the stage, but let me just say one thing. I've been privileged in my career to receive several awards from different venues. As a physician, the reason I went into medicine was to help patients. Mom and Dad were doctors. I saw what they did, and I can tell you that no award means more to me than one that's given for patient care. So I really thank you, your organization, and I thank my patients for teaching me so much over the years. Thank you all.
Thank you, Dr. Krastowski. Thank you.